Good afternoon, everyone. Welcome to our educational info webinar today on Myeloma 101, Diagnosis and Treatment. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. Before we go on and before I introduce you to our great speaker today, I'm just going to go over a few notes. First and foremost, I'd like to thank our sponsors for providing us with educational grants to help make these webinars possible. So thank you to Amgen, Binding Site, Bristol Myers Squibb, Janssen, Takeda, and Sanofi. And without their help, it'd be hard to do these. Next, I want to, as I do with every webinar, I just kind of want to remind you that all of our webinars are recorded and they're available on our YouTube channel. So how do you access those recordings? You go to youtube.com or from your YouTube app on your phone or your tablet, same concept. In the search bar, you write Myeloma Canada, click search. One of the first links you'll see is our channel. You click on the big red button to subscribe. That'll basically, you'll become a member of our channel. And then once you subscribe, you have this little bell icon that you can also click on. By clicking on that little bell, every time that we put a new video on, you'll get a notification. So that's a good way to keep up to date to all the latest videos that we're putting up on YouTube. You can also access the recordings from our website, so myeloma.ca. In the menu here, you click on resources. Once you click on resources, the bigger menu will open up. You click on educational videos, and that'll just send you off to our YouTube channel. Last but not least, questions. So we're going to take questions during the webinar. We won't answer them during the webinar, but please, as they come to mind, type them in the questions box. So if you're on a computer, this is what it will look like. On the application or on an iPad, it's a very similar concept. There's a questions button. You click on it, you type in your questions, and you click on send. I'm going to receive all the questions. At the end of the webinar, I will ask all the questions to our presenter, and we'll go through all the questions until we're done. As long as we have enough time, obviously. So yes, please do send your questions during the webinar. It's very important so that at the end I'm able to ask the questions. So without further ado, I'd like to introduce Dr. Deepa Wadhwa, who is a medical oncologist at the BC Cancer Center in Kelowna. Dr. Wadhwa, thanks so much for taking the time today to join us.
Of course. Thanks, Gabe, and thanks so much to Myeloma Canada for organizing the session, and for all of you making the time to attend and learn about this complicated disease that hopefully you'll find some clarification on as we go through this presentation. So I thought I would approach this through cases. Sorry. There we go. I often find it's easiest to learn when I have stories behind concepts, and a large part of what I do is kind of understanding the patient's story in context of their disease. And I think that's what makes my job so gratifying, is treating not just the disease, but caring for the person, and also being aware of the caregiver. So as we go through the case studies, I'm hoping we'll address the questions that I've listed there. So what is multiple myeloma, and what are some of the epidemiological features, like how common it is, how do we make the diagnosis, what's involved with staging and prognostication, at what point do we recommend treatment, and what does the initial treatment look like, how do we monitor for relapse, and what are some of the supportive care treatments. And I'm hoping, most importantly, that there's a good amount of time for Q&A. I know a lot of our patients really benefit from that. So our first case is of Michael, and these are just hybrid patients. They're not any specific person in my practice, but sort of a representative example. 52-year-old male presented to his family doctor for a routine physical, and as part of that, he had some blood work done, and it was noted that his red cell count, the hemoglobin, was a little bit low at 129, and you've got the normal values there. And as part of the investigations for the low red cell count, serum protein electrophoresis was done, and we'll talk about what that is all about, and it showed an abnormal protein measuring 10 grams per liter, and that led to a bone marrow biopsy which showed 15% plasma cells. All his other testing was unremarkable, and his repeat red cell count actually went back into the normal range. So multiple myeloma is a cancer of plasma cells in the bone marrow. So myelo is the Latin word, I believe, for marrow, and the multiple just refers to the fact that there are going to be multiple areas involved with these abnormal plasma cells that are growing in the bone marrow. So it's not a very common cancer, about 1% of all cancers in general, but it is the second most common blood or bone marrow cancer. And in Canada, we see about 3,000 cases diagnosed per year, slightly more common in males than in females. And the average age is kind of mid to late 60s or early to mid 70s. We don't really know what causes multiple myeloma. There may be some connection to exposure to certain chemicals or radiation, but nothing's really been proven conclusively at all. There are some rare familial variants, but those are quite uncommon. So here's just an image showing that the bone marrow is in the center of the bone, and that's the factory where red cells and other cells are made. And this is where the plasma cells, unfortunately, grow and produce these abnormal proteins. So the top image shows your normal plasma cells, which are these mature white blood cells that are part of your immune system and produce antibodies that help fight off infection. And then the bottom image shows these abnormal plasma cells that are kind of growing in this unpredictable, erratic fashion, and they're producing abnormal proteins that are interfering not just with antibody production, but also they're interfering with the factory that's producing the cells. So this is a really important slide in the sense that most, if not all, of my patients are very keen to know what their most recent protein results are, what are the light chains, and we do rely heavily on following these markers to let us know how well the disease is working. So if you're not already familiar, this is an important concept. So the myeloma cells produce abnormal proteins that we pick up on blood tests. The two most common are the serum protein electrophoresis. And so here we see a spike where the abnormal protein is. So down below are the cells, and this spike represents the abnormal protein produced by the myeloma cells. And so about 80% of patients with myeloma will make an abnormal protein that we follow called a monoclonal protein. And then close to 20%, 15 to 20% will make a light chain. So overall, almost all myeloma patients, about 97%, will produce some form of protein, whether it's a protein on the protein electrophoresis or a free light chain that we can follow and monitor their disease progress. So how do we diagnose multiple myeloma? So we need to demonstrate 10% or more plasma cells in the bone marrow, or sometimes patients have these deposits on their bones and other places, and those are called extramedullary plasmacytomas. So occasionally we do end up biopsying one of those, and that shows plasma cells. So you need to have one of those plus a myeloma defining event. So prior to 2014, it was quite simple. We used something called the CRAB criteria, and it's this very helpful acronym that tells us about the end organ effects of the plasma cells and how we sort of recognize multiple myeloma and identify it as something that needs treatment. So the C stands for high calcium levels, which can often make patients quite sick, nauseated, loss of appetite, constipation, confusion, etc. The R stands for renal complications, so some sort of kidney failure, kidney problem, often protein in the urine. The A stands for anemia, like our gentleman that I presented, the low red cell count, and B stands for bone disease. And then in 2014, based on some research studies and review of some databases, they found that some other features predispose patients to fairly significant complications, and that meant that we should really intervene with treatment at that point rather than waiting for the CRAB criteria to develop. So we call them biomarkers, and the first is if there's a plasma cell population greater than or equal to 60%. So if there's more than 60% plasma cells in the marrow, even in the absence of the CRAB criteria, we would likely recommend treatment just because the risk of developing one of these CRAB features is so high, and we want to try to maybe intervene before someone ends up really unwell. Then there's something called the serum-free light chain ratio. So you'll recall I mentioned the light chains. And so if one of the light chains is so high that it's produced this abnormal ratio, that's another sign that the myeloma is progressing at a pretty rapid rate, and we want to intervene before we end up with kidney problems. And finally, if there's more than one lesion seen on MRI, that would be another reason to recommend treatment, and we would make the diagnosis of multiple myeloma. So when I see a new patient with multiple myeloma in my clinic, I kind of go through this process. Obviously, I want to understand how the patient came to be referred and sort of what the diagnostic workup to date has been like. I'm, very, I really want to know what symptoms they're experiencing, and then a physical exam to look for heart disease or lung disease, swelling, painful spots on the spine where I can feel that perhaps there may be something that needs urgent attention. And then looking at the blood work, truthfully, I've reviewed the blood work beforehand, but it's something that you scrutinize more carefully after you've met the patient, and you want to review their blood counts, review their kidney and liver function, look at their electrolytes, including their calcium. We want to pay close attention to their protein levels, so the findings on the protein electrophoresis test, the light chains, beta-2 microglobulin, which is a tumor marker that I'll talk about in a few moments. And most times patients have had a bone marrow biopsy, but not always. So we want to look to see what's the percentage of clonal plasma cells. And then we want to see if there are any abnormal genetic mutations. So not something that a patient has inherited, because we don't tend to see inherited mutations with myeloma. It's very uncommon to see that, but more spontaneous mutations that have developed in the process of the plasma cells growing. And that will tell us a little bit about prognosis and sort of tell us about whether, how high risk their disease is. And then bone imaging is really important. In the past, we used skeletal surveys, which are X-rays, but now the vast majority of our patients get whole body CT scans, which are basically three-dimensional X-rays, and those are very sensitive for picking up bone lesions. So this is an important slide, just in context of the case that I presented. So there's active multiple myeloma on the end, but often there's a progression. So patients will often start off with MGUS, which stands for monoclonal gammopathy of undetermined significance. So that's when there is a protein, but they don't have the 10% or more plasma cells in the bone marrow, and they certainly don't have any of the CRAB criteria or any of those biomarkers that I mentioned. But generally, they do need to be observed because there's a risk about 1% per year over time that they will develop active multiple myeloma, and it would be important to identify those patients. Next are patients with smoldering multiple myeloma. So these are patients that do meet the plasma cell percentage criteria. So they have more than 10% plasma cells in the bone marrow, but they don't have any of those myeloma defining events. So they don't have any symptomatic CRAB criteria, and they don't have the biomarkers that I mentioned, the higher than 60% plasma cells, the MRI finding, or that light chain ratio greater than 100. And these patients do need to be followed carefully because there's a 10% risk per year that they will develop active multiple myeloma. So generally, we do not recommend treatment for these patients, but mainly close observation. And then, of course, there are the patients who have developed full-fledged myeloma, and they have myeloma-defining events, and they certainly require or would benefit from treatment. So this is an old staging slide. So this is how we used to stage myeloma. We use the tumor marker called beta-2 microglobulin, which is a blood test. And generally, the lower the level of the tumor marker, the lower the stage. And as the tumor marker goes up, higher the stage. So there are 3 stages, and the median survival in months is listed there on the end. And now we do a test called FISH, which helps us identify genetic mutations, which will increase our abilities to prognosticate more accurately and give us a better sense of how the disease will progress, so its natural history. So certain mutations, so I'll start with the standard risk first. So that's thankfully the majority of patients, 60%, fall into the standard risk category. And they have these mutations that I've listed there. So what the T1114 refers to is it's a translocation where part of one chromosome migrates to the other chromosome and vice versa. And that mutation tells us about how aggressive the patient's myeloma is likely to be. And then moving to the intermediate risk, which is about 20% of patients, there's different mutations we look for. And then finally, for high risk, these are the mutations that really do worry us a little bit. And we do try to think about maybe some alternate strategies than our usual, just to see if there's ways that we can manage it a little bit more aggressively, knowing that it's high risk disease. So we now integrate the genetic abnormalities into the staging. So we use both the tumor marker plus the genetic mutation to give us the stage. So I like to think of it as using both behavior and biology. So the tumor marker gives us a sense of the behavior, the extent of the disease, how high the tumor marker is, and the genetic mutations will give us a sense of the biology and how aggressive the disease is likely to be. We also use a blood test called LDH, which stands for lactate dehydrogenase. And this is often a non-specific test, but in the context of myeloma, it has been shown in research studies analyzing thousands of patients with myeloma. It's been shown to give us information about the aggressiveness of the disease. So if the LDH is high, that will lean the patient, or there's a higher chance that the patient will be in the higher stage category. So Michael, I've been following him since 2013. He's had an M protein that has fluctuated between 8 to 13 over the years, but he's doing really well, no signs of end organ damage. So we're just continuing him on close monitoring. I see him once a year to keep an eye on things. So second case is John, and he's a 64-year-old male that was previously healthy. He developed some aching discomfort in his rib cage, which led to an X-ray, and that showed these lesions that we describe as lytic in nature. So they're kind of destructive and wanting to chew up the bone, involving the ribs and sternum. His blood work actually was all normal, including his protein test. He ended up having a biopsy of the sternum bone in the center of the chest, which showed abnormal plasma cells. And then he had a bone marrow biopsy that showed 50% plasma cells. So based on the presence of the bone lesion plus the 50% plasma cells, he had a definite diagnosis of multiple myeloma. His serum light chains were really high, so he's one of the 20% that doesn't make the monoclonal protein, or his myeloma doesn't make the monoclonal protein, but makes the kappa light chain, which was quite high. And the genetic testing on his bone marrow showed a translocation in 414, which puts him in the intermediate risk category. And obviously, because he was quite symptomatic, we got him going on treatment urgently with a common triplet therapy that we use. So a 3-drug regimen called CyBorD, which stands for cyclophosphamide, bortezomib, and dexamethasone. And I'll go into sort of what these treatments are and their mechanism of action. He also started on a bone strengthener called zoledronic acid. So some X-ray findings in myeloma, these brown shadows here, as denoted by the arrows, are what are the lytic lesions. And now, as I mentioned, we're using CT scans pretty routinely to check for bone lesions. If I have suspicion that there's likely something in the bones, but I'm not picking something up on CT, then we'll move to MRI, or even PET scan can often be quite helpful. Bone scans are not, however, usually beneficial in this disease. So the top images show X-rays, and it can be sometimes subtle to tell on X-rays and a little bit more obvious, at least to a trained eye of a radiologist, on CT to pick up these bone lesions. This is an image of an MRI of the spine. So these are the vertebrae, and you can see these white patchy areas, which are the myeloma deposits. And here is the spinal canal, and the spinal cord lives there. And so you can imagine if the vertebrae were to break down or the cancer were to grow in that area, it could cause problems on the spinal cord, which can result in a lot of pain and disability for patients. So bone disease is really important to pick up. This is just an image of a PET scan where the black spots are showing the bone areas involved with myeloma. So John had induction chemotherapy with CyBorD. His light chains came down beautifully, and he went for a autologous stem cell transplant at the nearest big center to me, which is Vancouver. And his light chains were still normal after that. And he then began maintenance therapy with bortezomib, which is a drug that seems to be beneficial, in particular in the maintenance setting, for certain genetic abnormalities. So the translocation that he had, which put him in the intermediate risk category, is what caused us to recommend bortezomib for his maintenance treatment to try to keep his myeloma in remission for as long as possible. And he carried on with the bone strengthening agent, given that he had quite a few bony spots. So this is a kind of a busy slide of all the various systemic therapies that we have available in myeloma. So just in broad strokes, I want to talk about the big categories. So for a number of years, we were really relying on the first two categories, steroids and alkylator agents. So steroids are basically potent anti-inflammatory drugs that have a big effect in myeloma, especially when you combine with other drugs, and they remain the backbone of treatment. Alkylator agents are standard chemo drugs, meaning that they tend to affect healthy cells as well as cancer cells. But we do tend to still use cyclophosphamide in particular in combination with other newer drugs. So now in the last, probably 15 years at least, we've been using these newer, more targeted agents. So bortezomib, like my patient John was on, and then a second generation version called carfilzomib, and then there's an oral version called ixazomib. And of course, all of these drugs have trade names as well, but for the purpose of this talk, I'm just using the medical name. So the second category in these newer novel agents is the IMiDs, or immunomodulatory drugs. And these drugs work on the immune system by bringing up some proteins and suppressing some other proteins. And the ones that we use regularly in practice are lenalidomide and pomalidomide. Both are oral, and these are derived from thalidomide, which was found to be useful for myeloma in the early 2000s, but has a number of toxicities, including causing nerve damage. So we've kind of migrated away from using that regularly. The third category, the most recent development has been these monoclonal antibodies that specifically target markers on myeloma cells. And the three that we tend to use in clinic are daratumumab, isatuximab, and elotuzumab. Daratumumab is most commonly used, and these other two are often used more sort of later on in lines of therapy or as part of a trial. And then stem cell transplant, which is basically a fancy way of giving the body a really big dose of chemotherapy. And we're able to do that safely by giving them back their own stem cells, which we have collected prior to the high dose chemotherapy. And the transplant is a way of kind of consolidating the remission that the initial induction serves to achieve. And then finally, there are some new emerging therapies that are looking like showing a lot of promise, but at the moment are not used in a standard way in clinic. So that includes CAR T-cell therapy, antibody drug conjugates, which are basically antibodies that are tagged onto some chemotherapy, and it just allows sort of easier delivery of chemotherapy in a more targeted way to the plasma cells. And then some other drugs that are used in combination with existing agents. So this slide is mostly just to kind of show you guys the time period in which these drugs have kind of been developed, and to show that, I think progress is there, progress is being made, but sometimes it feels like it can't happen fast enough. So some of the older drugs were the alkylating agents like melphalan and steroids. Transplant is actually a relatively old technique, but it's still a very crucial part of our treatment for most patients, or some patients. I should talk about sort of which patients we recommend for transplant, and I'll get to that shortly. And then these novel agents that came about in the early 2000s, and then the antibodies, which came out in the last 4 or 5 years. So when we treat someone with multiple myeloma, the first thing is to decide whether they are transplant eligible or transplant ineligible. And we make that designation, it's not always straightforward. There is sometimes an age cutoff, and generally in Canada, the age cutoff is 70. And what we found is that past the age of 70, often the risks of the stem cell transplant outweigh the benefits. And because there are so many newer drugs being developed, we hope that the patient will benefit from multiple lines of therapy, even if they aren't recommended to go through a stem cell transplant. So typically the two options for treatment in Canada would be CyBOR-D, which is a pre-transplant regimen, but certainly can use it in transplant ineligible patients as well, particularly when I'm trying to get a fast response on someone. I want to use a 3-drug regimen. And then lenalidomide and dexamethasone is another really good regimen, more for patients that are not going to be going through a stem cell transplant. And often it's a continuous treatment, whereas the first one is more time limited. And most recently in BC, we've now got access to VRD, which is bortezomib, lenalidomide, and dexamethasone. So we have those sort of three options to play around with in Canada. In the US, they have access to more options. They are able to access this antibody first line. I hope we will too in Canada. It seems like it's in the works, and that's for patients who are transplant ineligible. So maintenance therapy typically is recommended more for patients post-stem cell transplant. So our patient, John, got bortezomib as a maintenance strategy after his stem cell transplant, and that's because he had this translocation that made him, we knew that he would likely benefit from this therapy to kind of keep his myeloma in remission for as long as possible. The more common agent we use, however, is lenalidomide. And what studies have shown in the last few years is that not only does it seem to keep the myeloma in remission for a lot longer than if you didn't take lenalidomide, it also seems to increase longevity. So for the most part, all our patients are now being recommended to undergo at least lenalidomide, sometimes bortezomib instead, post-stem cell transplant. However, all of these treatments do come with risks and side effects, so you do have to have that discussion. But generally, the worry about the existing cancer is enough that we would likely recommend some form of maintenance treatment in the stem cell transplant population. So this slide is basically to kind of illustrate how it's really important to achieve a deep response with treatment, and often the first treatment that we give a patient is going to be the most effective in terms of bringing down the burden of the myeloma. And sometimes it can seem on surface like you bring down the protein, and I've had patients ask me, okay, so my protein dropped from 40 to 2, can I stop treatment now? And often I say to them, well, there's a lot of disease that we sometimes can't measure in standard ways, and the deeper the response, what we found is that generally the better patients do. So there's a concept called minimal residual disease, and researchers are looking into whether giving treatment to try to get patients to the point where you can't see any residual disease by some of these fancier techniques that we use, not just a blood test, but sometimes repeated bone marrow biopsies, whether that seems to have a difference on outcomes. But for now, anyway, what we know is that the lower the M protein, the deeper the response, likely the longer the duration of remission. So my last case is of an 80-year-old female, and she had a number of medical conditions. So she had an arrhythmia that's fairly common as we get older called atrial fibrillation. She had high blood pressure, COPD. She had type 2 diabetes requiring insulin. And she was found to have a low red cell count. Her red cells were quite low, below 100. And her protein test found her to have a large monoclonal protein measuring 45 grams per liter. And her bone marrow biopsy showed 40% plasma cells. So she was diagnosed with multiple myeloma. And because I think I inherited this patient, but she started Sideboard D, that triplet regimen that I mentioned earlier, and her protein dropped, but didn't come down a lot, and it kind of plateaued at 24. We weren't able to get it down any lower, but her red cell count was stable above 100, and she was feeling well and had a number of side effects with the chemotherapy. So we decided to pause and take a break and monitor her carefully. And within a year, her protein started to go up and her red cells started to fall again. And so we then started her on lenalidomide and dexamethasone, which is an all-oral treatment strategy, and her monoclonal protein dropped nicely to 3, even though we ended up having to use quite a low dose of lenalidomide because she had side effects and sort of interactions with her other medications. But despite that, she had a very good response, and her red cells also improved. So when I monitor patients for relapse, typically we see them anywhere from every month, depending on how they're doing, to every 3 months. And we keep a careful eye on their protein tests, so the serum protein electrophoresis and their light chains. So we're looking for either a rapid rise in their protein or some features of end organ damage, so that CRAB criteria that I talked about, the high calcium, renal disease, or anemia, which is the low red cells. So if we see any of those things happening, then we want to move forward with recommending treatment for relapse in a timely way. And generally we do screening kind of CTs as well every 6 to 12 months to keep an eye for any bone lesions. But we obviously want to know if patients are having any new symptoms, any new bone pain, and they would let us know, so we would investigate more urgently if any of those things arose. So supportive care, this is a really important part of the care of a patient with multiple myeloma. So as we talked about, bone disease can obviously be very disabling and hard to manage. So the bone strengthening agents are really important. Radiation as needed for pain relief. And then sometimes when myeloma affects the spine, it can cause collapse of the vertebrae, and sometimes we need to do a procedure called vertebroplasty to help kind of stabilize the vertebra, and that helps to reduce pain. Infections are unfortunately an all too common reality with our patients who not only is their antibody production affected by the plasma cells that are not producing antibodies appropriately, but they're often on treatment which suppresses their immune system. Some of them treatments like bortezomib, for instance, can increase your risk of shingles. So we do put our patients on prophylactic antibiotics or antivirals. We emphasize the importance of vaccines like the flu shot and the COVID vaccine more recently, the pneumonia vaccine. And what we're finding is that with some of these newer agents like the monoclonal antibodies like daratumumab, we're also finding that patients are developing, recurrent pneumonias, and we want to try to manage that with IVIG, which is an immunoglobulin. So that's something that we're becoming a lot more aware of recently, is giving IVIG to prevent those pneumonias. Treatments like lenalidomide and pomalidomide can put people at risk for blood clots. So often our patients are on either blood thinners for other reasons, or they're on baby aspirin to try to prevent those clots. And then if patients have bone disease, they're often on analgesic or pain medications. It's really important to avoid drugs like ibuprofen and Motrin because they are so hard on the kidneys and also can upset the stomach. So we're using more things like Tylenol, the bone strengthening agent, radiation, and we often have to have our pain and symptom management or palliative care team involved to help with sort of managing pain and other problems. And then steroids, we're trying to get away from using those long term. There was recently a study that came out showing that you could do an initial treatment strategy including steroid like dexamethasone, and then after 9 cycles you could get rid of the steroid and it didn't make any difference in their outcomes. So we're trying to minimize the use of steroids because they can have a lot of effects on mood, sleep. They can be bone thinning. They can put you at risk for diabetes. So we're just getting more and more cognizant about how to kind of minimize some treatments while maximizing sort of quality of life. So in summary, multiple myeloma is a complex, multifaceted disease, and I think really benefits from team-based care. It is a highly treatable, but at the moment incurable cancer. Lots of hope and promise with some of the newer treatments that are becoming available, and we're seeing more and more drugs being approved on an ongoing basis. The diagnosis is made with bone marrow biopsy and the presence of a myeloma defining event. The goals of therapy are to reduce disease burden, prevent and minimize complications, extend the duration of remission as long as possible while boosting and maximizing quality of life. That's it for me. So thanks very much for your attention. And yeah, I'll pass it over to Gabe.
Thanks, Dr. Wadhwa. That was lots of information. Thank you for sharing all that with us. I just want to remind everyone that this was recorded and it will be on our YouTube channel. So if you missed anything, you could always go back. You can pause it on a slide. You can look at it as long as you want and really absorb the information. So you always have that option. So thank you for those that did submit some questions. And so it's all, the challenge is always, which question am I going to ask first? And so I think we're going to start with, you did mention a little bit at the end with dexamethasone and maybe lowering doses or maybe less is more. Perhaps what would be a good way to put that. So what are your thoughts on, in someone over 7 years old, either reducing the dex dose or even just stopping it? Is that something that's feasible for some patients?
Yeah, I think so. I mean, I think a lot of times we do things because they've always been done that way. But I think what we're realizing is that multiple myeloma is a really heterogeneous disease. And just like every person is different, every patient's disease is different. So I think it depends on, how well controlled the protein is, what the side effects are. Are there ways to schedule the dexamethasone a bit differently? Do we cut the dose back? If the protein has come down beautifully, then often I will, and the side effects are problematic, I will often suggest getting rid of the steroid. And yeah, I think the fact that this recent study came out showing no difference after that initial 9-cycle period with the dexamethasone, this was a study using lenalidomide and dexamethasone, I think that's given me more it's given me support now to make some of those decisions in clinic that I already was kind of leaning towards doing, and because I think quality of life is obviously a big concern to our patients.
Yeah, quality of life is definitely very, very important to patients. It's a reoccurring theme that we hear all the time, and people want to live long and they want to live well. That's what everybody wants, right? The next question I have here has to do with you had mentioned a little bit at the beginning when we did when you talked about the staging and on the right hand side of the chart, maybe I can go there because the person asked if they could see it again, so I'll just go there very briefly. And we had seen medium survival in months. Now this is the old way, right, of the staging. And so how accurate are these numbers still today? This was in 2005. So with
I think that overall, when patients ask about prognosis in clinic, and often that's an important question and things that patients really want to know, what to expect. We talk about averages, and it's sometimes hard because the average doesn't always apply to the individual. But in general, in 2021, the average survival for myeloma is about 5 to 6 years. As I mentioned, the standard risk patients are the majority, so that's 60% fall into the standard risk category. So 62 months is basically 5 years. So I think those numbers do hold up. But we often find that in the patients with the revised ISS stage 1, that we're seeing sometimes survivals as 8 to 10 years as listed on that slide. So a lot of it has to do with disease burden, the behavior, and then also the biology, so the genetics.
Okay, thank you so much for that. Let's go back to our question slide there. Okay, so the next question we have here has to do with, I guess we talked a little bit about how myeloma is not necessarily a disease that is genetic. So just because a parent has had it doesn't mean that the child will get it genetically. But is there a higher chance of someone who has a parent with myeloma that they will develop myeloma, even though it's small chance?
We haven't found that, truthfully. We haven't found that there's really any genetic susceptibility. You wonder if it is more environmental, that perhaps the parent and child have been exposed to the same environmental exposures. As I mentioned, there is that rare familial clustering of myeloma that sometimes happens, but in my 9 years, I haven't actually encountered anyone with such a significant family history that I've gone looking for that. But it is something that I'm aware of, and we always do ask about family history of myeloma.
So what would you say to someone who would present, for example, with anemia, but they have a parent who has multiple myeloma? Should they have a workup for myeloma?
Yeah, I think they should have a workup for anemia, and that often includes a workup for myeloma. So yeah.
Okay. Thank you. Now the next test, I'm just going to filter the next question. I'm just going to filter through this. Yeah. So what goes into finding out, what's the eligibility for stem cell transplant? What are the things you look at?
Right. Yeah, I think we often fixate a lot on age, but typically it also has to do with biological age. So, if someone has a lot of health problems and they're 65 and, are not, are quite unwell, even in absence of the myeloma, so even before the myeloma, they say they were debilitated by frequent issues related to underlying lung disease or heart disease. So in that situation, if their organ function is compromised, then their ability to tolerate that big blast of chemo that's required for a stem cell transplant just isn't there. And because there are newer agents that we can modify the dosing of to kind of accommodate those organ function issues, typically we would then, say that probably a stem cell transplant isn't in their best interest. So age is a bit of a criteria, but not always. You have to look at someone's medical history and also just how well they were functioning even prior to the myeloma diagnosis. It really is very much a risk-benefit kind of balance because a transplant isn't curative. I think it seems like an aggressive maneuver, so I think patients often and understandably think that it may be the best thing for wiping out the myeloma, but it really is just to kind of consolidate a remission. And if we can consolidate or have a deep remission by having continuous therapy, such as lenalidomide and dexamethasone, then that might be just as good as a transplant.
Thank you. So you had mentioned a 65-year-old and with some issues, and so I mean, is there a hard cutoff? Like, can an 80-year-old perhaps get a stem cell transplant?
I think it depends on the province and the country. So I know in the States, 77 is the hard age cutoff. In Canada, in most provinces, it's 70. I think maybe in Ontario, they'll recommend transplant for patients slightly older, especially if they have really high-risk disease and the patient's really well otherwise with no other health issues, and we know their myeloma is potentially going to really affect their life expectancy. It makes sense to try to hit it hard.
Thank you. Now the next question is, I think this question is referring to plasmacytomas. So basically the question is, PET scan showed that there's some bony involvement and there's treatment happening with radiation, but there's no plans for any stem cell transplant or anything like that. So is that something that is feasible?
Yeah, definitely. So we didn't kind of cover the spectrum of plasma cell disorders, but solitary plasmacytoma is on that list of other plasma cell cancers. And luckily, often patients can get away with treating that solitary lesion with radiation, especially if they've had a PET and you're quite confident that that was the only area. I had a fellow in my practice like that, and I think the key thing is just to follow them, because ultimately I think 5 years after his initial radiation, he did go on to develop myeloma. So it really is a spectrum of disease. I don't think it's like a hard and fast thing that you've had solitary plasmacytoma, so then you don't have myeloma. I think it is something that you need to kind of keep an eye on, and so that person would likely benefit from follow-up.
Okay, thank you. Now the next question, at the end of the presentation, you talked a little bit about orthopedic intervention or orthopedic surgery, such as a vertebroplasty or a kyphoplasty. Now, this person is asking for someone who's transplant eligible. I don't think that really makes a difference whether they're transplant eligible or ineligible, but unless I'm mistaken. So at what point would spinal surgery be considered? Is that something that the hematologist or the oncologist would decide, or is it usually something that's preferred, that is asked, that the orthopedic surgeon would decide?
Yeah, I think for these types of cases, often there's a discussion between the specialists. So, you know, I'll pick up the phone and I'll call either the surgeon or the interventional radiologist and kind of go over the case. And then we kind of put our heads together and sort of decide whether, you know, technically it's feasible. So that, you know, obviously that input comes from the surgeon or the radiologist. And then in terms of clinically how they're doing, you know, if they're in a lot of pain and it's kind of one area that the vertebra is collapsed, you know, it makes a lot of sense, and I would sort of advocate for that procedure. So I think it depends on both the clinical and the technical aspects.
Mm-hmm. Thank you. I'm going to ask a question because I did get an email from a patient a few days ago asking about rods and femurs. Is that something that would typically be done, you know, to make sure that the femur doesn't break if a weak femur is found, or is it usually done just to repair a broken femur?
You know, sometimes we do the prophylactic pinning surgery, and that's when, you know, it's a weight-bearing bone. So if it looks like it's going to be quite vulnerable, then we will refer patients for that surgery. And it's obviously such an important thing to try to avoid a fracture. Yeah.
Thank you. That'll be helpful for my response. So next here I have, so someone's asking for, you know, we talked about that the average age of diagnosis are in the late 60s, early 70s or so, or something like that. How, you know, someone who's diagnosed really early, like in their 50s, you know, is their prognosis a little bit different than someone who, for example, would get diagnosed later in life?
Yeah, it's a good question. I think it's more, you know, I think at the end of the day, it still comes down to the disease burden. So the ISS and staging, the tumor marker, how high that is, and the genetics. I don't think necessarily the younger you are, the more aggressive the myeloma, although I have had cases where that's turned out to be the case. Yeah, I think at the end of the day, it's still the biggest factors that tell us about how aggressive the disease is going to behave still has to do with the beta-2 microglobulin and the genetics, and response to treatment too, I think. So if someone has, you know, a really good deep response and you know, it's 4 or 5 years between their first line therapy and second line therapy, that gives us a lot of confidence that, you know, hopefully their disease can be managed for many, many years.
Thank you. The next question has to do with nutrition. We didn't really touch on this aspect, but the general question is, through this whole process, through the diagnosis, the treatment, stem cell transplant, how important is nutrition? And what are maybe some of your top line tips when it comes to nutrition?
Yeah, I do think nutrition is important, and I apologize for not kind of mentioning it, but it is, I think, part of that multidisciplinary approach, and I think that's why it is so good to be part of a cancer center or cancer clinic that has access to those services, because we know that when our patients have bone disease and they're in pain, there's muscle wasting, and so having a good diet where they're maintaining their weight, getting protein, is probably an important aspect of care. And I do monitor my patients' weights kind of fastidiously, and if they're dropping, that is a red flag. But it can also go the other way. A lot of the steroids can unfortunately, put the appetite on kind of ultra speed, and so you sometimes get weight gain issues, and then that sometimes can lead to difficulties controlling blood sugars. So it's a balance for sure. Typically, our main recommendation, apart from referring to a dietitian when patients have specific questions or we're worried about weight loss, my recommendation is to follow the Canada Food Guide, because it is so balanced, and it's concentrating on making sure that the diet is rich in fruits and vegetables, because it's not just about calories, but the type of calories.
And by that same aspect, I mean, exercise, I would assume, is also something that's, safe exercise is probably something that you advocate for as well.
Yeah, definitely. I wish there was more sort of research done on the benefits of exercise, because anecdotally in clinic, you see the patients that are able to regularly walk and do some gentle exercise, whether it's walks or time on the stationary bike. You just anecdotally, it feels like their outcomes are better, but I understand that it's not always possible for everyone, and but I think within your limits, sort of listen to your body, but I do think that some activity is a really good thing. Helps with preventing blood clots, helps with preventing pneumonias, because your lungs are expanding and you're getting good blood circulation. So yeah, I do think it's an important thing. Yeah.
Thank you. Now this question is what is the natural course of the disease from the time of diagnosis to its end?
Yeah, so I think, we've sort of, I think what we're starting to realize in a very profound way is that myeloma is many diseases, that everyone is different, and their context and sort of their values are their own, and then the treatments are sort of tailored towards values, but also sort of the biology of the disease. So I think, I hate to say it, but it's kind of like the answer is it depends, right? It depends on sort of the extent of the disease burden, the medical issues that someone could be facing. But in general, what we tend to see is that patients go through multiple lines of treatment, and we want to try to maximize each line of treatment before moving on to the next one. And ideally, if we can, it would be nice to have some periods where you're on treatment breaks, especially between first and second line. Often there is a opportunity for a treatment break. So that's kind of the general scope of the disease, is kind of getting someone through multiple lines of treatment to extend their remission and survival, but being careful to manage the treatment so that quality of life isn't impacted too strenuously.
Thanks. And this next question, I'm just going to ask it, and knowing that you don't have a crystal ball, but I don't know what you could maybe say about this, but the question is, what is the survival rate beyond 5 years with multiple levels of treatment in recent years? So someone who's been on a lot of different treatments, after 5 years of treatment, what's their prognosis or survival look like?
Yeah, I think a lot of it kind of has to do with how the person is doing at that point after 5 years. You know, if they're generally well and functioning fairly close to their usual self, and you know, their blood work and their complications are minimal. The fact that they've kind of made it 5 years, hopefully that means that, you know, the natural history is such that there's still years ahead. And I think that likely if you've made it to that point and you're feeling well, it's unlikely that your longevity is going to be measured in the order of months. So I know we talk about that 5 to 6 year average, but by no means is that specific to any one individual. It's just on aggregate, because we have some patients who unfortunately, you know, it's more like 1 to 2 years, and they obviously skew the curve, skew the averages quite a bit.
Yeah, that makes sense. Thank you. So we have 2 really quick questions left. The first one I'm going to ask you is with a new diagnosis, what are some of the best things family and friends can do to support the patient and their immediate family? Now, before you answer the question, I just want to let this person know that we do have a caregiver handbook at Myeloma Canada. It's free. It's available on our website, and it's free. And there's lots of tips and tricks and ideas for how to support someone who's going through a diagnosis. So I just want to hear from you, Dr. Wadhwa, what your thoughts are on that.
No, thanks for piping up with that, Gabe, because I do recommend often to patients, because it is such a complicated disease and there's so much to keep track of. I think it's good to, if you can, now that the restrictions for COVID are easing, if you can either bring someone to the appointment or have them join in by phone, just have an extra pair of ears. But I also find it's very helpful to get hooked up with a patient community like Myeloma Canada. I've had a number of patients now tell me how they've really benefited from it. So now I do try to put it in my sort of internal checklist of things, is to point them towards these resources, because it, you know, I think knowledge really helps, gives you a sense of a little bit more control when you can feel a little bit like things are out of your control. So I would encourage you to get involved. Yeah.
Yeah, thanks for that, and thanks for your recommendation. One of the things that it says in that book is, you know, get to know what myeloma is, and by just knowing what myeloma is and how it could affect a person, that'll give you more ideas on how to help someone. You know, or it could be as simple as cooking a meal, or like you said, going to the appointments, or so on and so forth. There's lots of different things that you could do. So thank you. And the last question, since we're 1 minute over time, I would be remiss if I didn't ask you this question, because it's the hot topic these days, as you can imagine. And now with people getting vaccinated and getting their first doses and their second doses, there's lots of questions about the presence of antibodies and antibody testing for COVID-19. So I guess the simple question is, if someone gets tested and they don't have antibodies against COVID-19, does that mean that they're necessarily don't have protection against COVID-19?
Oh wow, yeah, question. Yeah, you know, I think we do worry that our patients maybe with myeloma who are on treatment aren't able to make the same antibody response as those who are not on treatment or don't have myeloma. The truth is, I'm not sure how accurate the testing is. I think I'd have to kind of look into seeing sort of, you know, is one test method, you know, fully validated in terms of knowing that. I think we're still learning. I mean, this whole year and a half has been sort of incremental learning, right? When we first were exposed, or when we first learned about COVID and its impact, you know, initially we weren't recommending masks, and then we realized that it is an important thing to do. And so I have to say, I think it's still a little bit murky. So we're still figuring that out.
Yeah, and there are studies underway throughout the world that are trying to answer these questions, and I believe there will be studies in Canada, or studies that have probably already started, or will start very soon in Canada, that will try to answer that question on exactly how protected is a myeloma patient after 1 or 2 doses. So once we know that, then we'll be able to answer those questions a little bit better. Yeah. So with that, we'll end the webinar. So thank you. I don't have any more questions. Thanks a lot again for taking the time to do this. It was very helpful, and I wish you a great rest of your day.
Yeah, thanks, everyone.
Thanks. Bye.